Good morning and welcome to Medicine Grand Rounds. It's really my pleasure this morning to introduce Alex Lepak. Alex is a native of Wisconsin and we've kept him in the state throughout his illustrious career thus far. He's a graduate of with a Bachelor of Science in Medical Microbiology and Immunology, so was differentiated early on. Then came to medical school here, where he extended med school by a year as an NIH-mentored medical student research program awardee. He then took his residency here in internal medicine, his clinical fellowship in infectious disease, and then research fellowship in ID, as well as serving as a clinical instructor and research fellow for a year before we successfully recruited Alex onto the faculty as an assistant professor of medicine. Now already he's really defined an area and has published extensively with 28 publications in peer-reviewed journals focusing on fungal and bacterial infection. He's authored 5 book chapters and 40 abstracts. He's been supported by an NIH loan repayment during his fellowship with that program, and he's a collaborator on the large U19 grant here in the Division of Infectious Disease and across the campus. He's also a co-investigator on a number of other industry-sponsored grants. He is truly a triple threat. In addition to his science, he's an active educator, teaching CME, classroom, clinical wards for residents and fellows, and mentoring thus far already 2 undergraduates and 4 postgrad research fellows. He's a very good citizen locally and beyond. He provides clinical service for Meritor, the VA here, and as well as at the University Hospital, where he works in the Antimicrobial Stewardship program, and they've even done some work for Monroe Hospital as well. He's involved as the clinical director for infectious disease e-consults and is a travel clinic oversight physician. He is a good citizen nationally as well, reviewing for 7 journals and even serving as a grant referee for the Netherlands Organization of Scientific Research. Along the way, he's been honored as a Ruth Kirkstein National Research Service Awardee and George McCracken Infectious Disease Fellow. He's given a number of talks locally and some nationally as well in his area of expertise. We're really fortunate to have him deliver grand rounds today entitled Our Wits Versus Their Genes, Antimicrobial Resistance in Ambulatory Medicine. Please join me in welcoming Dr. Alex Lepak.
All right, thank you very much for everyone who was able to make it today, and certainly thank you to Dr. Page for that kind introduction. It is really a pleasure. I've been coming to Grand Rounds since 2002, so almost 14 years, and it really is a pleasure and honor to be up here today presenting to you. So if we've learned anything from probably the past week, it's that predictions can be quite dangerous. I won't say anything more political necessarily about that, but predictions in medicine can be equally dangerous. In 1969, our own Surgeon General, William Stewart, wanted to close the book on infectious diseases, declare the war against pestilence won. And this wasn't just blind hubris necessarily. From 1940 until the late 1960s when he made this comment, we really had a boon in discovery of antibiotics. There were more than 20 classes of antibiotics discovered over that 20 to 30 year period. And so certainly the future looked bright, but we needed to kind of keep our eye on the ball. And many people recognize this. I think one that's very prescient is someone very close to home. So Joshua Lederberg, for those who are Wisconsin historians, came to the University of Wisconsin in 1950, and he ended up winning the Nobel Prize for discovery of plasmids, which I will talk about in a few slides exactly what those are, but he very presciently said that the future of humanity and microbes likely will unfold as episodes of a suspense thriller that could be titled Our Wits Versus Their Genes, and hence the title of my talk. So there's a number of objectives today that I'd like to cover. First and foremost is the significance of antibiotic resistance, which I think many of you are at least somewhat aware of the problems that we are running into. But also, why does it happen? Why are bacteria so good at developing resistance? I want to touch on a number of ambulatory settings where resistance is common. And certainly there's a lot of areas that I could touch on. Truly, a talk about antibiotic resistance could last for hours and hours, and we certainly don't have that kind of time. So I wanted to pick 4 kind of areas that touched on various areas of medicine: recurrent uncomplicated urinary tract infection, macrolide resistance for Streptococcus pneumoniae and how that might impact community-acquired pneumonia treatment, gonorrhea, and then finally uncomplicated skin and soft tissue infection, or as many of you probably know it as cellulitis. I'm going to touch a little bit on prescribing practices for antibiotics in which they're not bacterial in origin. And we really need to get a grasp on this as a medical community. We definitely need to do better. And then finally, if you've been paying attention to the news throughout the summer, there's been a lot of news about drug resistance in gram-negative rods and how we're running out of therapies. And I will touch a little bit on that at the end. So let's start with antibiotic resistance. I think we need to use the correct frame of reference when we think about antibiotic resistance. So first is that we did not invent antibiotics. Many people think that we did as a scientific community, but we discovered their existence. But antibiotics have actually existed since the beginning of time. Bacteria have used chemicals or products that they make to inhibit or kill other bacteria, to gain competitive advantage, to survive, and this has been going on forever. And in fact, if we look at resistance mutations, this isn't something that's only come out in the last 50 or 60 years since we have started using antibiotics. Resistance mutations actually date back billions of years in some cases. And so if we think about it collectively, microbes have had the experience of creating, dealing with, and defeating antibiotics that other bacteria may make for 20 million times longer than we have actually known they existed. So what makes them so adaptable? There's 4 things. I'm going to touch on 3 on this slide and then 1 on the next slide. But there's 3 things in this slide that make them extremely adaptable to changes in environment. And that's the replication process, the ability to mutate, and then selection. And many of you out there will immediately recognize this is the process of natural selection. This is exactly what Darwin described. So E. coli, for example, can replicate every 20 or 30 minutes. That means that even conservatively, if you were to pick 30 minutes, in 24 hours, you can make 281 trillion progeny from one single bacteria. And potentially a better way to wrap your head around the numbers here is that in 19 hours, one bacteria, one E. coli bacteria, could make more progeny than the number of humans who have ever lived on Earth. So that's an amazing number. Their replication process is supposed to be error-prone. This is purposeful, that they make mistakes when they replicate. And this is a process whereby they can then test for genetic advantage of various mistakes. And that genetic advantage is selected for under pressure, whether it's an external environmental pressure or an antibiotic or chemical. But what makes them exponentially adaptable is the fact that they don't have to go through the replication process to necessarily change, to adapt, or to become resistant. They can exchange genes, drug-resistant genes even, horizontally from one bacteria to another. And that's through the process of plasmids, which Dr. Letterberg discovered and ended up winning the Nobel Prize. Plasmids are extrachromosomal, or they can be chromosomal DNA segments that bacteria can directly exchange with another bacteria. And these genes are often multiple, so they can pass not just one type of resistance mechanism, but multiple types of resistance mechanisms to another bacteria. So, again, using, I think, the correct frame is that it's not necessarily a question of if resistance might develop in an antibiotic. It's really a question of when. This is a chart showing clinical introduction of an antibiotic. So not necessarily the date of discovery, but the date that the antibiotic was clinically introduced. And that's the green dot that you can see here. And the length of the arrow is the time in which resistance was not observed. And I think you'll all very much appreciate if we look from about 1980 on, these arrows are incredibly short. Part of that reason is that we have not had new classes of antibiotics. Most of these antibiotics that have been released in the last 40 or 50 years are modifications of already known or produced antibiotics. So let's get into a few clinical scenarios. Recurrent uncomplicated urinary tract infection. I imagine all of you out there have dealt with this process at least a few times. It is certainly common in females, and the most common pathogen is still E. coli. 2/3 to 3/4 of urinary tract infections are due to E. coli. Other Enterobacteriaceae can produce urinary tract infection and are listed. And at least the definition of what makes something recurrent is also listed for you. But I think a good place to start before we tackle resistance is, can we prevent resistance? And the answer to that is most certainly yes. And that is to not treat asymptomatic bacteria. There have been plenty of studies looking at this. And in the chart on the bottom, I'm showing you the level of evidence. And so this is very high level of evidence. It's almost A1 level evidence for every clinical scenario to not treat asymptomatic bacteria. Of course, there are exceptions like the pregnant female, but in essence, we know very strongly not to do this. And in fact, we know a number of things can happen if we do. And you can use these to explain to patients why you might not want to treat them for asymptomatic bacteria. So we know that it doesn't change the infection rate, or at least it doesn't decrease it, but it may actually even increase your infection rate by treating it. You don't change survival. You significantly increase the chance that that patient's going to have a drug-resistant isolate in the future. So you make the possibility of their future true infections harder to treat. And you significantly increase the chances that they're going to have an adverse event or a side effect by giving them the antibiotic. I'm going to show you two studies from the same group of authors that hopefully hit this point home. This was a study of females who had recurrent UTI, and they randomized these patients who had asymptomatic bacteria and recurrent UTI to either treatment with an antibiotic or no treatment. And they followed them over a 12-month period. And as I'm sure you'll appreciate, that at 12 months, if you did not get an antibiotic for asymptomatic bacteria, your rate of infection was dramatically lower than if you did get an antibiotic for asymptomatic bacteria. The relative risk was over 3-fold higher. So we actually increased the chances that the patient had a symptomatic UTI by giving them an antibiotic for asymptomatic bacteria. Now, some people might wonder what would be the plausible explanation for that. And the theory would be that these asymptomatic bacteria that are located there may actually be performing a function of blocking the more pathogenic bacteria from moving in. So you give them an antibiotic, you alter the microbiome of the area, and the more pathogenic bacteria are then able to cause disease. What happens to resistance if you treat asymptomatic bacteria? Well, they also looked at this. It's the same group of authors, the same patients, and they looked at what were their isolates, what were they susceptible and resistant to 3 different antibiotic classes. And if you did not receive antibiotics for asymptomatic bacteria, the rates of resistance were statistically lower than if you did. So, at least in this study and the previous study, you increase the chances that they got infection, and you increase the chances that they now have a drug-resistant isolate that's much more difficult to treat. When we do have drug resistance, I think there are two antibiotics that are very helpful for drug-resistant UTI, and I'm going to touch on those today, nitrofurantoin and fosfomycin. So nitrofurantoin is a very interesting drug because it's been around for a very long time, and yet resistance in E. coli is still incredibly uncommon. Most studies, less than 2% of E. coli are resistant to nitrofurantoin. In our own internal data, over an 8-year period, we had 99% susceptibility from urine isolates for E. coli to nitrofurantoin. Unfortunately, lower rates of susceptibility for other Enterobacteriaceae. Now, one myth that we've tried to deal with over the previous years is use in reduced renal function. And that is because the package insert for nitrofurantoin has creatinine clearance of 60 as a cutoff. And what's interesting is the original FDA approval was 40, and there's really no clear data for why the change was made at some point to go from 40 to 60. And in fact, now a number of experts have looked at this and have recommended it down to a creatinine clearance of 30. And I think what's very telling is that in 2015, the American Geriatric Society published their recommendations about drug therapy. And in it, they were strongly in favor of using a creatinine clearance of 30 for nitrofurantoin use in the geriatric population. How effective is it as we have more and more resistance in bacteria? So this looked at nitrofurantoin activity in E. coli from outpatient urine cultures in the United States from 2001 and 2010. You can see there's a lot of isolates, 30,000 isolates. Unfortunately, fully susceptibility, dropped by 10%, and multi-drug resistance increased equally by about 10%. But what they looked at this, and they looked at a number of comparators. I'm only including Cipro here to make it a little more brief, but they included TMP sulfa and beta-lactams as well, and the numbers are quite similar, as they looked at if your E. coli was more resistant, so if it was resistant to 1 drug or 2 drugs or 3 drugs or 4 drugs, what were the chances that it was resistant to nitrofurantoin in both of these years, and what were the chances that it was resistant to ciprofloxacin in both of those years? And you can see nitrofurantoin maintains excellent susceptibility, even as the isolate gets more and more drug resistant. If you were resistant to 4 different antibiotics, the chances that nitrofurantoin was still susceptible was greater than 90%. And as you can see with ciprofloxacin, that is dramatically different. One, the rates of resistance dramatically increased from 2001 to 2010, and certainly as you became more drug resistant, the chances that ciprofloxacin might work were exceedingly low. Fosfomycin is a drug that some of you are probably familiar with. It's a very efficacious one-dose treatment for uncomplicated urinary tract infection. It can be somewhat challenging to get in certain outpatient settings and can be expensive. However, it is gaining interest because it is highly effective against resistant Enterobacteriaceae, and especially E. coli. So there's been a lot of studies. This one is 17 studies. It's a meta-analysis of 5,000 drug-resistant isolates and 3,000 ESBL isolates. And they looked at how effective would fosfomycin be against these isolates, whether it was all Enterobacteriaceae, so they grouped them all together, and then they broke them down for E. coli and Klebsiella pneumoniae. And I'm sure you'll appreciate here that if you were resistant to or if you had advanced drug resistance phenotype, your susceptibility to E. coli was still exceedingly high, or certainly ESBL positive, which we see a lot of those. The percent susceptibility to E. coli, again, was quite high. A little bit of a step off when you get to some of the other Enterobacteriaceae, unfortunately. So let's move on to pneumonia, and specifically macrolides and macrolide resistance. So I'm giving you a case here of a relatively healthy 57-year-old guy. He's got a classic kind of presentation for pneumonia. His CURB 65 score is low. It's 1. His pneumonia severity index is only 3. So he's an appropriate patient for ambulatory type care. His procalcitonin is clearly positive, consistent with a bacterial disease, and he's got this nice lobar consolidation. I mean, this is our classic community-acquired pneumonia. And he doesn't have risk factors that you'd think of necessarily for drug resistance per se. So the IDSA guidelines on this would actually strongly recommend macrolide therapy. And I'm sure most of you are probably familiar with that. These guidelines are unfortunately about a decade old. And they added in a caveat in it that I think is difficult for a lot of people to necessarily interpret or understand. It's probably difficult even for a lot of infectious disease people to necessarily interpret. Is they make this caveat, though, that if the local antibiogram data reveals that greater than 25% of your strep pneumonia isolates contain high-level macrolide resistance, and they define that as an MIC greater than or equal to 16 for macrolides, that then you should consider an alternative. And unfortunately, most labs certainly don't report high or low-level MIC resistance. You're probably lucky, especially at a lot of community labs, if you can even get macrolide susceptibility for some of your pneumococcal isolates. But any resistance would be an MIC greater than or equal to 1. So what is the state of resistance for Streptococcus pneumoniae? It's not good, certainly. In our own internal data, again, this is an 8-year period, 2005 to 2013, the strep pneumonia isolates that were tested, 95% were susceptible to ceftriaxone, 99% were susceptible to fluoroquinolones, 52% were susceptible to macrolides. This data is congruent with other larger studies. There was a multi-site study in 2005 that showed 35% resistant to macrolides, of which half of those would have met the definition for highly resistant based on what the IDSA guidelines had recommended. And a Sentry database survey done in 2010 that examined resistance over the previous decade clearly showed that susceptibility to macrolides was dropping dramatically over that decade from 82% to only 60% by 2009. Now, is this important? Does it affect outcome? We don't have a lot of studies on this, but there's one very nice study done in Canada. They looked at 1,600 cases of pneumococcal bacteremia to identify cases that occurred on macrolide therapy. So these are patients who were on a macrolide and then developed pneumococcal bacteremia while on macrolide therapy. And that occurred in 58 patients. Okay. Now, not surprisingly, as I'm showing in the table here, and I'm sure all of you would expect this, you were, of course, dramatically more likely to have bacteremia or macrolide failure if you had an isolate that was resistant to macrolides versus those that were susceptible to macrolides. But I think what is very interesting about this study is that when they looked at the failures across the MIC spectrum, the failures occurring in low-level MICs, so 1 to 8, were as many as the failures that were occurring in MICs greater than or equal to 16. So this study at least would suggest that the more traditional MIC breakpoint of 1 confers quite a bit of prognostic information about treating Streptococcus pneumoniae. So we certainly await updated guidelines, and we hope the updated IDSA guidelines will be out next year. However, until then, things will remain a little bit gray. And what do we do about macrolide resistance and treating patients with community-acquired pneumonia? Resistance is a huge issue. Unfortunately, as I'm showing here, we are the clear leaders of all the countries in macrolide resistance. And so I would certainly caution, though, using macrolide monotherapy in patients who have a history of macrolide use, especially recent in the last 3 or 6 months, and especially in patients who have probably a higher pretest probability for streptococcal disease. We know not every case of pneumonia is caused by strep pneumonia, so that's one issue here. But certainly in patients who have a lobar pneumonia, who are presenting classically with a streptococcal disease, macrolide monotherapy is not likely to be the best choice for that patient. So gonorrhea is a disease that is increasing in the United States and throughout the world. We have almost 500,000 cases per year, and this is definitely low and not the true number because it's only what gets reported. And it's estimated that it's probably 3 times that amount in the United States. In the world, there are more than 80 million cases of gonorrhea in a year. So this is a huge disease throughout the world. I put in here to hopefully hit home the concept that we sometimes think of sexually transmitted infections, and certainly gonorrhea, as something of teenagers or young adults. So this colored map here, if you will, breaks up the cases by age group. And if you were to spend a little bit of time looking, you'd realize that 50% of the infections are occurring in patients who are 25 and older. So this is not just a disease of teenagers and young adults. Prior to 2007, we had a number of treatment options. In total, we've probably gone through at least a dozen different treatment regimens for gonorrhea over the past 50 years or so. But at least prior to 2007, we had fluoroquinolones, or 2 different types of cephalosporins, oral Cefixime or IM ceftriaxone. And then we had this report from the CDC. This is an exponential curve of drug resistance to fluoroquinolones. So at that point, it was clear that fluoroquinolones were not going to be effective anymore for gonorrhea, and it was pulled from the guidelines. 2012, we have Cefixime failures in patients, so we have patients who are being treated with Cefixime and not clinically cured. Then we also have evidence of rising resistance. Now, these rates were still far lower than fluoroquinolones, but Cefixime was a cephalosporin, ceftriaxone a cephalosporin. There was a lot of concern with the clinical failures and the rising resistance to Cefixime that our only and last bastion, ceftriaxone, might be next. And so Cefixime was pulled from the guidelines, and we were down to just ceftriaxone, and then later added azithromycin to the recommendations as well, which I will show you some resistance data about that in one slide. So the state of resistance today is certainly not good. Only about 60% of gonorrhea isolates are fully susceptible to antibiotics. I don't expect you to be able to go through all of these different pieces of the pie, if you will. But suffice it to say, resistance is seen in 40% of isolates. Multi-drug resistance is seen in 20%, so half of the 40% are multiply resistant. Tetracycline resistant, which is not used anymore, was used in the past for gonorrhea, is still 25%, despite the fact that we haven't used it in decades. And fluoroquinolone resistance, we don't use fluoroquinolones, haven't used it since 2007, and yet the resistance rates are still quite high. Many of you out there are probably wondering, what about ceftriaxone? This is our last drug. What's kind of happened? The rates, it's not zero. It's not zero, but the rates have remained relatively stable between 0 and 1%, with a few kind of blips here and there. Unfortunately, azithromycin resistance, since that was added into the guidelines, has now skyrocketed in the most recent year of looking at this. We all kind of wait nervously to see what this happens next in 2015, 2016, as they're able to compile all the isolates and release their reports. But suffice it to say, the treatment guidelines today for gonorrhea are double therapy for everyone, and it's a slightly higher ceftriaxone dose than you might have learned or might remember. It's 250 milligrams IM ceftriaxone and a whole gram of azithromycin taken orally. If you've ever tried to get a person to take a whole gram of azithromycin, you'll understand that can be quite challenging. The gastrointestinal side effects can be very problematic. How much worse can it get? Worse would be a nice way to put it. So just about 2 months ago, the CDC reported in Hawaii a cluster of cases of patients having gonorrhea where there was reduced susceptibility or resistance to both azithromycin and ceftriaxone. So we now have within the United States at least isolates that are potentially resistant to both of our antibiotics that we use to treat it. Skin and soft tissue infection, there's a lot of teeth gnashing, I think, about skin and soft tissue infection and cellulitis, especially in primary care. I think a lot of people still struggle with where do I and who do I put on MRSA coverage or MSSA coverage or strep coverage. How do I make this clinical decision of what to give them? Or maybe I just give them an antibiotic that tries to cover everything. And this is really a disease process that is still highly dependent upon the physical exam. And so you need to use your clinical exam skills to figure out what kind of treatment algorithm to use. And really the place to start is to look at the affected area and ask kind of a simple question of, is it fluctuant? Is there pus? Is it open and draining and purulent? Or is it a classic kind of fire engine, red skin, hot, painful? And I put two representative pictures here because these are two very, very different disease processes. The bottom one is your classic streptococcal cellulitis, and the top one, of course, is something that most of us are familiar with, is likely to be community-acquired MRSA or potentially MSSA soft tissue infection. Now, one thing that's important is to not miss the opportunity in that initial setting to debride an abscess if it's present. This can be curative for patients who have small abscesses. So that alone can cure the vast majority of patients. But it also lets you or it also gives you the opportunity to get source control and get some culture information, because you certainly may need that culture information to make appropriate antibiotic decisions as the patient clinically progresses over the next few days. So I've used this slide before and made it to kind of help, I think, describe to people how to think of what some of these antibiotics optimally cover. We have drugs that optimally cover primarily streptococcal infection, which would be penicillin or amoxicillin. Drugs that are going to cover streptococcal infection as well as susceptible Staph aureus, so cefalexin, ceftriaxone, amoxicillin, clavulanate, and dicloxacillin, for example. Drugs that can cover strep, susceptible staph, and resistant staph, that would be clindamycin and linezolid. Now, clindamycin, as many of you are aware, the rates of resistance can be elevated, especially in MRSA isolates. And so susceptibility testing to clindamycin does need to be confirmed for staph. And then drugs which only are going to be beneficial for covering staph, so MSSA or MRSA, and that's TMP sulfa and the tetracyclines, doxycycline and minocycline. These drugs, and we still see some of this today, are not going to be very reliable for streptococcal disease. And so if you have a streptococcal cellulitis, they are unlikely to be very effective. There's a number of studies on skin and soft tissue infection. I wanted to go through a few that I think help kind of hit home the points about differentiating these types of disease processes to purulent or non-purulent. So a very large study published in the New England Journal of Medicine looked at patients with cutaneous abscess. These patients had an abscess and erythema greater than 5 centimeters. So these were, sizable infections. All patients had debridement. And they randomized patients to TMP sulfa, it's 2 double-strength tablets twice a day, versus placebo. And clinical cure was statistically higher in the TMP sulfa group. So certainly it favors use of TMP sulfa for this disease process, along with IND. But I think you can look at the other side of the coin here and say, look at how effective just IND was. And these were patients with sizable abscesses, and 73% of them in the placebo group were still cured with just IND. So certainly an antibiotic seems to help these patients, but the effect of that antibiotic is not that large. Is there a difference between Clinda and TMP sulfa? We don't necessarily have the answer to that. Certainly, some of that's going to be highly dependent upon the rates of Clinda resistance within your community. Our outpatient data of patients presenting with skin and soft tissue infection that ends up being MRSA, we have about 40% Clinda resistance. So that's going to impact how likely Clinda would be effective versus TMP sulfa. There was a study presented at ID Week 2 weeks ago that compared placebo to clindamycin to TMP sulfa in this same kind of clinical scenario. And TMP sulfa and clindamycin both performed slightly better, statistically better, than placebo. Now, in that study, the rates of clindamycin resistance, though, in their cohort were very small. But nonetheless, until that makes it through the peer review process, we're not completely sure, but there's unlikely to be a huge difference unless there's a lot of clindamycin resistance within the community. Uncomplicated cellulitis, this was a very nice study done that basically examined for uncomplicated cellulitis without purulence, so the classic fire engine red skin, hot, painful, do I need to add MRSA coverage to my empiric regimen? Because they looked at cephalexin versus cephalexin plus TMP sulfa. And there was no difference in clinical cure. Patients did well in both groups. And so the point of this study is that you do not need empiric MRSA coverage for a classic uncomplicated cellulitis. And a final study, this was retrospective in nature, but I still think is very nice to kind of hit home the effectiveness of beta-lactams for uncomplicated cellulitis. In this retrospective study, they looked at beta-lactam therapy versus non-beta-lactam therapy. Most of the beta-lactam therapy was cephalexin. Most of the non-beta-lactam therapy was clindamycin. There was a trend towards decreased failure in the beta-lactam group. What may have made that trend stronger, which wasn't included in the article, was the dosing of cephalexin that they used. Cephalexin can be dosed 250 to 500 milligrams for each dose, and anywhere from 3 or 4 times a day. Certainly, if you ask any infectious disease expert, based on the really rapid clearance of the drug, the optimal way, and in my mind the only way to treat uncomplicated cellulitis is 500 milligrams 4 times a day of cephalexin. So if they had potentially undertreated some patients, that may have diluted some of the effect. There was statistically increased adverse events, statistically increased discontinuation in the non-beta-lactam group. So the take-home would be that beta-lactams are very effective for cellulitis, for uncomplicated skin and soft tissue infection, and you are likely to have less continuation and side effects if you use a beta-lactam over using a non-beta-lactam drug. And clindamycin has some MRSA coverage, so again, the addition of MRSA coverage did not seem to impact outcome. So this is a simplified flow chart. We have one on UConnect for treatment of skin and soft tissue infections. The IDSA, the Infectious Disease Society of America, has a guideline on this that's more complicated and complete, but for simple purposes, if you have a patient with suspected uncomplicated skin and soft tissue infection and they're appropriate for outpatient therapy, you really need to think purulence versus non-purulence. The non-purulent infections, you really only need streptococcal coverage. So that's amoxicillin or cephalexin or dicloxacillin, for example. You should probably only vary from beta-lactam therapy if the patients have a true and severe allergy, making beta-lactams not usable. And for purulent infections, do not miss the opportunity to get source control. Do not miss the opportunity to get some culture information to help you make decisions. For patients who have smaller infections and they're otherwise healthy, IND alone is likely to be sufficient. For larger ones, the addition of TMP sulfa, clindamycin, the tetracyclines, or linezolid would potentially cover MSSA and MRSA. So, outpatient antibiotic use and some issues and inappropriateness that we see in terms of non-bacterial infections. There's been a number of studies looking at this. The Pew Charitable Trust published their results this past summer. They found that at least 30% of outpatient prescriptions were inappropriate. Other studies have actually found up to 50% of outpatient antibiotic prescriptions being potentially inappropriate. They identified a number of areas for significant improvement. And I put these 5 here and then listed with the percent visits in which antibiotics were prescribed and the percent that you would expect are truly bacterial in nature and truly need an antibiotic. So for example, sinusitis. 72% of patients who went to their clinician with sinus symptoms, sinusitis as a diagnosis, left with an antibiotic. Whereas it would be expected that only about 2% of cases are truly bacterial in origin and need an antibiotic. We can look at diseases which, in their title, would tell you they're not bacterial. Viral URI, 30% leave with an antibiotic. Obviously none should probably have really necessarily needed an antibiotic. Non-suppurative otitis media, again, 20 versus 0. Acute bronchitis, very common. Very, very common. Very unlikely to be truly bacterial in nature. 65% get antibiotics. Less than 1% truly are bacterial that would potentially need an antibiotic. So we need to do better. However, we need to balance this with modern medicine. So there are a number of things we're trying to do in modern medicine that are very important. So we worry about patient convenience and clinician convenience. We worry about efficiency. We want clinics to run efficiently. We worry about patient satisfaction. And those are all important aspects of care, certainly. But they can lead to very curious decision making. So this is a Facebook post from a person who was unfortunately suffering pharyngitis. So the person says, I went to bed with a scratchy throat and woke up with my throat on fire. This typically means I'll lose my voice for a couple days. To my coworkers and family, you're welcome. It's kind of ha-ha, funny. So next day, the person posts, just had my first virtual doctor's appointment. 10 minutes at my desk using my webcam and antibiotics for a sinus infection with bronchitis called into the pharmacy. I hope a number of you are kind of scratching your heads out there about a few aspects of this. One, this person's been ill for 1 day, and they get antibiotics already. They don't go to see anybody. Like the symptoms were pharyngitis. So wouldn't you worry about strep throat? You might want to look at it, do some testing, right? And the diagnosis that the person gets is sinus infection with bronchitis. I thought it was about a sore throat. So, this is unfortunately part of modern medicine. We're trying to make things convenient for people. We're trying to satisfy expectations, and we have to balance that with doing the right thing. And we know that patient satisfaction has been positively correlated with antibiotic prescription. That's been well published and well proven that patients go to the physician or ask the physician for antibiotics, and they're gonna be satisfied when they get them. But all is not lost, because there are also studies that show that there is one thing that can trump satisfaction in terms of patients who have upper respiratory symptoms and are going to a physician or looking to a physician for an antibiotic. And unfortunately, that's time. It's time spent with the patient. When patients get an explanation for what is going on, actually, why they don't need an antibiotic, how they can expect their symptoms to progress and transpire over the coming days, what they can symptomatically do to control it, what kind of warning signs should they look for, when should they call, when should they come back. All of these things are important aspects that take a lot of time to explain. And in fact, I saw one study where they polled patients who were coming into the physician with respiratory complaints before the physician visit and after. And the part of the visit was meant to counsel them and spend some time with them. And the patients who came out after the clinician visit who did not get an antibiotic, only 10% of them still said that they probably wanted one. So that means 90% of people who on the pre-visit said they wanted an antibiotic, 90% of them left relatively satisfied that they were not getting an antibiotic. So what can we tell patients? I think there's a number of things. I think 4 things really come to mind about why it's not a good idea for them to get an antibiotic if they don't need one. They can have severe and life-threatening superinfection. We've all had patients with C. diff, I'm sure. They can have side effects that can be severe and life-threatening, and these can be from the antibiotic itself, or they can be from interactions with their other drugs. It can promote drug resistance in that patient, making future infections they have more difficult, potentially even impossible to treat, depending on the level of resistance. And to try and engender, I think, a sense of community, that this is not good for the community. This promotes drug resistance in the community. It makes it more unlikely to be able to treat their friends and family who might get an infection, and even future generations. So I want to touch a little bit here before we end on resistance in gram-negative rods, because that certainly has made some news. So the last new drug class for gram-negative rods was discovered in, I think this will probably surprise many of you, 1961. So the quinolones were the last new class. We've had a lot of new drugs over those years, but those are modifications or alterations of already known existing classes. And beta-lactams, though, have largely been the mainstay of therapy for gram-negative rod therapy, especially Enterobacteriaceae. Unfortunately, we have ESBLs now. I'm sure all of you have seen those, extended-spectrum beta-lactamases. Those render most beta-lactams, except the carbapenems, resistant. There are some exceptions. Some ESBL enzymes are still susceptible to cefepime or piperacillin tazobactam. But in general, carbapenems kind of become the go-to drug. And then there's carbapenem-resistant Enterobacteriaceae, which is resistant to almost all beta-lactams with only a few kind of nuanced exceptions. It's a world map of ESBLs. E. coli isolates, 80 to 100% ESBL positive, India, Bolivia. Those 2 countries, if you have an E. coli isolate, it's almost guaranteed to be ESBL positive. In the United States, we're at between 10 and 20%, but it does certainly vary by geographical location. CREs, which are even scarier, again, India gets to kind of take the cake here. More than 50% of their Klebsiella pneumoniae isolates are CRE positive. You can see a smattering of other countries where it is also elevated. In the United States, it's between 6 and 20% in general, although, again, there is some geographical variation. CREs have been associated with 40 to 80% mortality. So these are very, very scary bugs. Within the United States, the most common mechanism is KPC positive organisms, and we've seen them now, and as of 2016, they're in just about every state. Idaho and Maine are the 2 states where it hasn't been necessarily found as of February 2016, but certainly it will be found there very soon. Closer to home, we have had not as many CREs as other states, certainly. We've been lucky thus far, although things will probably change if you look at our neighbors. So in Wisconsin, we've had 36 CREs in 2014, 65 in 2015. It's kind of an equal distribution of inpatient isolates versus outpatient isolates, although I think the concerning thing is that in the inpatient world, the isolates increased 3-fold from 2014 to 2015. So, and these are sicker patients. These are patients that cannot really afford to get infections with this isolate. If you look in Illinois, 1,600, it's not a typo, 1,600 CRE isolates in 2014. Chicago, In the loop, 737. The suburbs, 591. If you look at a population basis to try and relate these numbers, because obviously the populations of Chicago, Illinois, and so forth are different than Wisconsin, even based on population, the rates in Illinois are somewhere around 20-fold higher for CRE than they are here in Wisconsin. We are going to share patients with them, no doubt. So we will see these patients in the near future, I'm sure. And then if you've been paying attention to the news and a number of my colleagues have been at the front lines of commenting on this discovery over the summer, and that is the kind of the dawn of potentially untreatable gram-negative rod infections due to polymyxin resistance. So colistin, which is our last kind of line of defense for gram-negative rod therapies, especially serious infections. Colistin resistance was recognized in 2015 in China due to a plasmid-mediated mechanism. So this is something that could be passed from bacteria to bacteria. Since that discovery, it's now been identified on 5 continents. That's listed here on the map. And we've had at least 4 cases in the United States of MCR1 gene-mediated resistance to polymyxins. So to end, I think we need to also change a little bit of the frame of how we think of antibiotics. Antibiotics are a shared resource, much like clean water or clean air. This is something that we all share amongst all of us as providers and patients and for future generations. And if we don't really take on antibiotic resistance, we run the risk of having a situation where the most innocuous injury or infection could kill patients of all ages, and that includes young, healthy people. It happens today. And there's a lot of medical therapies that we provide that we aren't going to be able to provide, or at least aren't going to be successfully providing if our patients are dying from drug-resistant infections. There's hardly a procedure out there that doesn't rely on proper antibacterial prophylaxis, for example, or all of the things that we can do to patients, implantable devices, transplants, therapies for debilitating rheumatologic diseases. All of these, if we can't properly treat their infections or prevent their infections, we are not going to be able to provide these therapies. And I think what's very interesting and telling is a study done by the United Kingdom looked at the current state of affairs, and they asked the question, if we're not able to get on top of this, if we're not able to alter the way that antibiotic resistance is going, by 2050, we're going to see more people dying from drug-resistant infections than die today of diabetes and cancer combined. So that's greater than 10 million people will be dying from drug-resistant infections. So I'll end with just a few summary slides. Antibiotic resistance is here to stay. UTIs, please treat only the true UTIs, and nitrofurantoin and fosfomycin are highly effective against drug-resistant gram-negative rod UTIs. Macrolide resistance and Streptococcus pneumoniae has really exploded in the United States. Gonorrhea, we're on the last regimen for right now. There are some new drugs in development, but at least for now we're on the last regimen, and there is even some resistance to that. Not every cellulitis needs MRSA coverage. Treat it kind of according to purulence or no purulence. We really need to do better with outpatient antibiotic prescribing. And I think one unique way to think about this, which I kind of try to wrap my head around myself, is how many, for how many medical things does a patient go to a doctor expecting to get therapy for it? I mean, does a patient who comes in for a hypertension checkup, are they disappointed that they didn't get that extra antihypertensive? Or are they disappointed that they didn't get the cholesterol medicine? Or are they disappointed when the surgeon says, you don't have to have surgery, right? I mean, that's, patients aren't disappointed by that. Patients going in with, a cough or the sniffles or whatever, they are disappointed if they leave without an antibiotic and, importantly, don't understand why. And that's going to take time and effort on our part. And I think we all need to optimize this because we certainly all want to do the right thing, but in terms of optimizing patient satisfaction and efficiency and so forth, we need to not inadvertently be incentivizing doing the wrong thing. And really, we've been called into check by antimicrobial resistance. We need to do something now about this. We certainly cannot ignore it. So I have a lot of people to thank, and I'm running out of time. But I've had two of the greatest mentors that someone could ask for: Dave Andes and Bill Craig. The UW Antimicrobial Stewardship team has been very helpful to me over the years, and I've had a number of really, really excellent clinical mentors that I couldn't thank enough. And of course, my family, my wife, and my son. Thank you.
That was great, Alex. I'll ask you to call on the audience. We've got time for just 2 or 3 quick questions and quick answers. And please repeat the question.
Dennis.
Cefixime or Exponentially for an MSSA infection when we can use dicloxyphilin. Neither of these very narrow spectrum penicillins won't C. diff. The others clearly do, and they're far more expensive. That's a comment. The question is, have we really paid enough attention to the duration of antibiotic therapy? Only 10 years ago, the standard therapy for sinusitis would be 3 weeks. We now know probably 3 days to 5 days is enough for proven bacterial sinusitis. For treating urinary tract infections much shorter. Should we be looking at all infections, treating them much more briefly with diminished antibiotic direction?
So the comment was about using even more targeted streptococcal type of coverage for cellulitis, like amoxicillin or PEN-VK, and I certainly couldn't agree more. Unfortunately, most of the studies use cephalexin. That extra MSSA coverage, likely not necessary, right? But that's what a lot of people have done with studies. And then the follow-up question to that comment was, have we focused enough on treatment duration in terms of studying some of these diseases? And most certainly the answer to that is that we haven't. Although we are certainly doing better for both skin and soft tissue and pneumonia. In the past year, there's been a number of studies looking at shortening the duration of therapy. And in each of those scenarios, shorter worked very well, worked certainly as good as longer. And so I think we definitely are starting to push the envelope of shorter is better for most infectious diseases. The one exception, which I'm sure you would agree with, would be like Staph aureus bacteremia. But most things shorter is better. Mm-hmm. And we need to study it better, though.
One last question.
Alex, great talk. I'm wondering, are we really, is there a role here for really ramping up the fecal transfer therapy, or whatever nice name you want to give it? Particularly, I think about, for example, on pregnancy patients that spend days on broad-spectrum therapeutic antibiotics, and, it seems to me if there's some role of reestablishing the normal microbiome immediately afterwards, we would subsequent risk down the road as they end up.
Yeah, so the question is about using fecal microbiota transplant, especially in the hematologic and bone marrow transplant patient population where there's heavy antibiotic exposure and certainly high risk for C. diff disease. And certainly there is a potential role, and a lot of people are looking at fecal microbiota transplant for various clinical indications, irritable bowel disease and so forth too, but even in kind of a preventative or prophylaxis type measure to help reconstitute a GI flora faster. And so I certainly think there is. I think the jury is still out about whether or not that's going to be beneficial. One of the risks you certainly run in that patient population is that they are heavily immune suppressed, and you certainly want to do no harm first. And so it does, take a careful screening process to make sure that when we're giving the fecal microbiota transplant, that it's safe to do it in that patient population. But certainly, I think it's a ripe area for continued investigation.
With that, we need to close. I want to encourage us all to remember our veterans, this being Veterans Day, and I want to thank Dr. Lepak for an excellent Grand Rounds.